himself. He's been in consultant of sports medicine and working as MSK for a long time, and has multiple publications. Is the author in many books. So he's going to talk to us today on ankle joint, the ultrasound. So Dr. Mahesh, please.
Okay, can I, am I audible?
Yes.
Okay, thank you. Thank you, Dr. Sania. First of all, at the outset, I thank the BSRI, the office bearer of the society, Dr. Mahbuba, and all the people who are involved in the organizing the meeting for the kind invitation. So as after extensive comprehensive talk by Dr. Laura, we'll just see that how the ultrasound can help in the people who are the radiologist or the sports physician for the evolution of the disease process. As we all know that the ultrasound is significantly useful for the soft tissue injury or soft tissue pathology. So we'll see, like in 25 to 30 minutes, we'll see how the ultrasound of the ankle, we can do and we can see all the structures and we can see the pathology. So I'll share my screen and I'll so just let me know if it's visible. The screen is visible to you, all of you?
Yes, it's visible.
Okay, thank you very much. So as I said, I will be discussing the ultrasound of ankle joint, how we can do it. Although, like when we are doing the ultrasound, usually when we demonstrate, is always good to see, and then we can demonstrate how to put the probe, where to put the probe, and that is most useful. But still, I will try to show you how we can do the ultrasound of the shoulder of the ankle joint. So let's see. So we all know that the ankle joint is a big joint, complex hinge joint, and is surrounded by the multiple ligaments and the tendons. Various conditions of the ankle, like sports injury, inflammatory, infective arthritis, and pathology involve the ankle joints. As we all know that the ultrasound is recently, I think in last 10 years, is emerged as a very, very good modality to evaluate the soft tissue structures. And we can do like all the joints, like shoulder joint, ankle joint, knee joints. Particularly the shoulder joint is very, very useful, particularly the rotator cuff. But we can do the lot of other joints also. And I always say, because I do ultrasound, MRI, everything, so I always say this point, and I think this is the point we should all remember, that the ultrasound and MRI is a complementary technique. It's not a competitive modality, because many times people say the ultrasound is better or the MRI is better. They're complementary, and whenever possible, we should use both of them. And because many of the structures, they are not seen on ultrasound, and they are well seen on the MRI, but we all know that the MRIs remain the gold standard, but definitely ultrasound play a very, very important role, particularly soft tissue things. So what is the advantage of ultrasound? We should understand that there is a very good, as I said, is very good for soft tissue structures. Portability, like particularly in the sports, the injuries, like even like these small the ultrasound machines are available, and you can take it to the field where the players are there, and whenever the players get injured, and then you can also do the ultrasound there. So this is very, very the important advantage of ultrasound, that is portable. Apart from that, cheaper, faster, and better tolerated than MRI. We all know about it. Another important thing is we can do the dynamic examination, which is not usually possible by MRI. So like we can see the tendon glide and kind of impingement, any structural impingement, then you can definitely do by the ultrasound. Another important thing which I have used, and I feel it's very, very useful, and whenever possible the radiologist should use it, that we can interact with patients. Many times that patient tell you that this is, here is the I hurt the most, or the pain is there, and then you can definitely put the probe there and to identify the abnormality there. So this definitely is very useful, because MRI is not like kind of where like usually we ask the patient or just, so it's definitely we can interact during the examination and definitely is useful. There are some limitation. We also remember the limitation that by ultrasound it's a limited evolution of bone, particularly the deepest part of the bone, like medullary regions, like bone marrow edema. You cannot detect by the ultrasound, so it's useful. But superficial structure, superficial component of the bone, like bone cortex, is still you can assess whether it's possible. The intra-articular structures like cartilage, as Laura showed, that cartilage, the injuries or menisci or cruciate ligament injury, they are not well assessed by the ultrasound. So definitely the MRI are useful, and this location. Only thing is that it's operator dependent, and slightly need to know that where how to see the structure, and we need to know about the normal morphology. So these are the we should understand where the ultrasound is more useful, where there is some limitation of ultrasound, and when there is a limitation of sound, then MRI remains the definitely a choice of modality. So let's see how the what are the techniques and equipment. We all know that nowadays the good ultrasound machines are available, and there's a lot of software and hardware advancement which there. So good machines, ultrasound machines are available. We like particularly for soft tissue structure and superficial joints, we should use the 5 to 70 megahertz probes, and nowadays is more megahertz probe, like 24 megahertz probes are also available. So whenever possible, at least we need to have a more than 12 to 15 megahertz probe. So whatever is feasible, whatever possible, whatever is available to you, we should use this one. You need to have a proper depth and focus. This is kind of whenever you do the ultrasound, you should do the optimization of imaging, and extended field of view, and as I said, the dynamic scanning are very, very useful whenever you're doing. There is another way that people usually say that if you do the systemic way of ultrasound, then it is, so that's why the chance of missing the structure or the pathology is limited or very less. So whenever possible, you should do the systemic way of examination. And I usually, particularly the joint, I usually use the ESSR guideline. They are very, they have very easy and very simple way they have demonstrated. And in this particular talk also, I have taken some of the images with the probe position from that document. And you can also, you can see the documents are available on internet. And definitely the people who want to start the MSK radiology by ultrasound, then definitely they can go through into it, and they are very useful and very simple. So let's go for the anatomy. We are not going to very detail about it, but you know the ankle joint is formed by the lower tibia and the medial that's called medial side, the medial malleolus, on lateral side the lateral malleolus, and the body of the talus. So these are three the bone which is articulating and making the ankle joint. So see, let's see for the example for the bone, what are the important ligament, like the syndesmotic ligament, which is between the tibia, lower end of tibia, and the fibula. So this is syndesmotic ligament. Anteriorly, we have a distal anterior tibiofibular, and posterior we have a distal posterior tibiofibular ligament. So these are three ligaments we can easily identify here. And these are the posterior, anterior, the ligament here. You can assess by ultrasound. Is very easy. I will show how we can assess later on. On lateral side, we have another three important ligament. One is the anterior talofibular ligament, and this is CFL, and this is posterior. And definitely, this is the anterior talofibular ligament is the commonest ligament get injured in the ankle sprain, and is quite easily you can assess by the ultrasound. So I will tell you how we can assess the ligament. On medial side, we have a quite big complex ligament that is also called the deltoid ligament complex, and it contains various components. Some people say also that is a superficial component or the deep deltoid complex. Deep deltoid complex is anterior tibiotalar and posterior tibiotalar. Important to understand that we should know which component is anterior, which component is posterior. Like this is anterior tibiotalar and this is the tibionavicular. And if you want to see the tibiocalcaneal, so this is this tibia and this is part of the calcaneal system. And so if you want to see this one, then the probe position should be here, not here. So that's why if you remember the anatomy, where to look for, then you put the probe in that particular location, and then you can easily diagnose or easily see that particular ligament and pathology. You can assess that way. Coming to the tendons, we have, as I said, there's a lot of tendons are there, anterior, posterior, and the lateral side. And we all know that the on anterior side, we have a tibialis anterior, the extensor hallucis, extensor digitorum. On lateral side, we have a peroneus longus and brevis just behind the fibula. On medial side, we have a tibialis posterior, flexor digitorum longus, and posterior, tibial posterior, and the flexor hallucis. So you can even, some people say this, you can easily remember by Tom, Dick, and Harry way, but we know that we have to assess all the tendons, and MRI is definitely by MRI you can see these ligament, the tendons, and we can assess how we can do by that sound. So as I said, this will do by the systematic examination. So I'll go from the anterior aspect and the medial and lateral and posterior aspect, how we can do it. So let's see how we can do our anterior aspect. So like this is the way we can just put it, the probe here. So you can put it, the probe, like in the short axis. So like in horizontal way. And if you put the probe here in horizontal way, then what will we see? You see all the extensor tendons, from extensor the tibialis anterior, extensor hallucis, and extensor digitorum, and then the vessels and the nerve. So these all structures are quite easily identified. So only thing is you should remember where to look put and where to put the probe. So you just put the probe at the crease here, and then you can see all these structures here. Another important thing, like when you are seeing in the short axis, it's very important. You have to see in the long axis also. So like here, so if you just put the probe, like initially we were putting the probe in the short axis in the horizontal way. If you just move the probe in the long axis, then you will see the tendon in the long axis way here. So usually, like, tendons are very compact fibrillary structures. You can easily identify, like if you know about the normal morphology of the tendon, you can definitely easily identify that this is the tendon. And if you like medially, then you have a tibialis anterior, and then you can go from the medial to lateral side to assess the every single tendon. So it is very easy. Apart from that, anteriorly, we have to, apart from the tendon, we can see the anterior recess of the joint here. So this is the tibia and this is the talus. So this is the anterior recess. So any kind of the joint effusion or synovial thickening, then you can it can be easily seen here. So these are the things which we must see on anterior aspect, apart from the tendon and the joint space and any abnormality which will be a synovial thickening or effusion in this location. So coming to the after the anterior aspect, coming to the medial aspect, we just put the probe, like this is the probe position here. So this is the medial malleolus here, and just put the probe here in that direction. And then if you put the probe here, what will be seeing? We see all the tendons. So first one is the tibialis posterior, and then it will be digitorum, and then it will be more posterior will be a hallucis, and apart from that will be here the nerve as well as the artery and veins. So these are all structure Tom, Dick, and Harry you can easily see if you go from from medial, anterior medial to the more posterior side. So you just put the probe and just identify all the structure. Is quite easy. Only thing, you have to put the probe in the exact position where to put the probe and how to identify all the structure. So as I said earlier, like after the short axis, you have to see the all the tendons and the ligament in the both the planes. So it's important. So here, like if you put the probe in the long axis, then this kind of the structure, which as I said is a tendon, you can easily identify the tendon, and you can, if you go from the more medial to most posterior aspect, and then you can identify the which of the tendon you are picking up, starting from the tibialis posterior to the, if you go more posterior, will be of the flexor hallucis. And if you, this is another the patient here, you can say this is the just fibrous band. Even the smaller structure like retinaculum you can easily identify. So this is the medial malleolus here. So and this component will be tibialis posterior, then the digitorum, and then artery and the vein, artery vein and the nerve, and most posterior will be the flexor hallucis. So these all structures are easily identified. Gives a very good resolution if you have the good probe, the high megahertz probe. So all the structure you can easily identify. Even the nerves, you can have the fascicular pattern of the nerve, you can easily identify by the ultrasound. So after the tendons and the nerves, and if you see more deeper, then you can see the medial compartment, the deltoid ligament complex here. Like here, this is the superficial component will be the tendon. And if you see here, this is the medial malleolus, and this is the talus. So this is the deeper, the ligament, which is the deltoid ligament. So this is the tibiotalar ligament. If you can appreciate this ligament, you can easily identify. And if you go slightly anterior, then you can see the tibiocalcaneal. So this diagram shows, like if you put the probe here, then it will be tibiotalar. If you put the probe in this direction, then you will be seeing the tibiocalcaneal. And if you put the probe here in the anterior direction, then you will be identified the tibiospring ligament or the tibionavicular ligament. So that's why it's important. It's always important. You know where to look for and where the ligament lies. So if any abnormality in the tibiotalar, you have to put the probe here and see the things. So anatomy for doing the ultrasound is always important. You should remember the anatomy, and just if you remember the anatomy, that doing the ultrasound and visualization of the particular structure is not difficult. So coming to the lateral aspect, we know about lateral aspect. We have the peroneus tendon, longus and brevis. So this is the lateral if you see this is the lateral malleolus. This is the bone here, and just posterior to will be the peroneus brevis and the longus. And this is, if you can appreciate from there, that this is small the hypoechoic structure which is just covering the peroneal tendon is a peroneal retinaculum. So that's why, like the smaller thin structure you can easily identify by the ultrasound. Only thing you should know that where to look for. And then I said that you have to look for in the long axis also, apart from this is in the short axis and this is the long axis. Then, as I said, this is the anterior talofibular ligament. Is the very, very important ligament if you are assessing the ankle joint. And this is the the lateral malleolus here, and you can see the ligament quite nicely here. So any changes, any disruption of anterior talofibular ligament in cases of ankle sprain, you can easily identify. So important thing to remember that you have to put the probe in the horizontal portion. So if you put the probe like this way, then you will not able to identify this anterior talofibular ligament. So you have to put the probe in the horizontal direction, and then you can definitely easily identify ATFL. And to identify the CFL, calcaneofibular ligament, you have to put the probe in this direction. So this is a more of vertical direction, and then we have to ask the patient to make a dorsiflexion. And that way the CFL, this ligament, become taut, and then you can easily identify. So this is the calcaneofibular ligament. So this is a fibula, and this is the calcaneum, and you can easily identify the CFL ligament. And the superficial to this ligament is the tendon, the peroneus longus and brevis. So you always remember that the CFL lies beneath the peroneus longus and tendon. And if you put the probe in this direction, you can easily see the calcaneofibular ligament. If you want to see the anterior inferior tibiofibular ligament here, we know that this is the way of seeing the anterior talofibular ligament. If you want to see the anterior inferior tibiofibular ligament, then they have to make the angulation, same angulation towards the superior aspect, so called the cranially. And if you put in this direction, oblique direction, then if you put the probe like this way, then you can easily identify the anterior inferior tibiofibular joint. Also, this is the part of syndesmotic we have seen in the anatomy slide. So this is the part of the anterior-inferior tibiofibular ligament, and if it kind of high ankle sprain, this ligament is can injured, and so you have to see this ligament in the high ankle sprain. So it's not difficult to visualize this ligament. Only know you should know where to put the probe, and then you can see that this ligament. Then after anterior, medial, and the lateral side, we have to see the posterior posterior ankle, and we all know that posteriorly we have a big the tendon here is the tendon Achilles, and tendon Achilles is attached at the calcaneum, posterior aspect of calcaneum. So this is the calcaneal tuberosity here, and you can see this is a very thick the fibrillary structure. This is tendon Achilles, and it's attaching at the calcaneum. You have to, this is the long axis and this is the short axis. So always remember, whether you are dealing with the patellar tendon or any tendon of the body, then you have to look for both the short axis and the short axis, long axis and the short axis to know where is the pathology, and just not missing the any abnormality or any tear in that location. So in here, there you can see that you just put the probe, very easy to identify. You just put the probe in the posterior aspect of the ankle, and then you can easily identify the Achilles tendon. This is the region of the Kager's fat pad. So any abnormality in this direct location, you can identify. This is the area you sometimes you can see the fluid in the calcaneal, posterior calcaneal bursa, but in the form of calcaneal bursa. You can see here the bursa or fluid or inflammation. Sometimes pre-Achilles bursitis can see in this location here, just superficial to the tendon Achilles. Without seeing the plantar fascia, we cannot complete the ultrasound of the ankle. So here you just put the probe in the plantar aspect of the foot, posterior aspect of the foot here. So this is the calcaneum here, and this is the heel pad here. And if you see this structure, this hypoechoic structure going from the calcaneal tuberosity here, like you see here, this fibrillary structure, this is the plantar fascia. So in cases of plantar fasciitis, this can be thickened here. People say it's usually more than 3 millimeter is the thickening, but sometimes it is more than, some say more than 4 millimeter. So 3 to 4 millimeter is borderline. More than 4 millimeter is the definitely the kind of the plantar fasciitis you can identify. And apart from that, you can see some the bony excrescences, some edema, or some changes in the plantar fascia itself can be easily identified the ultrasound. So after the normal anatomy and where to look for the particular tendons or the ligaments, then we'll see some of the common pathology which can be easily identified by the ultrasound. So let's see what we can see on bones and joints. So as I said, that the effusion, like ultrasound, by ultrasound the effusion can be seen in any joints here. So effusion, any kind of synovitis or arthritis, we all know that the ankle joint or the joints of the foot are involved with the various kind of arthritis, whether it is a osteoarthritis or rheumatoid arthritis or the non-specific arthritis, ankylosing spondylitis. So these kind of synovitis arthritis you can assess by the ultrasound because it's easily assessed and it's by the ultrasound. And then you can see some osteomyelitis or fracture which is superficial. Then you can assess by the ultrasounds. So let's see some of the example here. So here, like you see this case of the synovitis, you can see this is a fusion in this location, and there's a lot of synovitis, very thick synovitis, synovial thickening, hypertrophy, and then they can show some of the color Doppler signal here. And so, like the ultrasound is a good modality to assess the synovitis, like in the hand joint. So hand joint, like the ultrasound, remain the modality for choice, particularly the assessment of the rheumatoid arthritis and their the follow-up cases. So ultrasound is also very useful if there is some arthritis involving the ankle joint or the of the foot. So this case of synovitis and effusion. Sometimes different kind of arthritis, but like gouty arthritis or CPP, then ultrasound has a typical feature. So here, like see, this is the tibia here, and you can see the talus. And if you can appreciate from there, there is a linear same echogenic line just above the cartilage, the cartilage of the talus. So this is called a double contour sign. Here is very, very typical of gouty arthritis. So if you can see this finding, then you can definitely suggest that possibly we are dealing with the gouty arthritis. Then this is case of osteomyelitis of the talus. Here you can see there is irregularity of the anterior talar, the bone here, the cortex here, and then there is there's a collection. Or so this is a case of typical case of osteomyelitis. So you can assess if there is a superficial the irregularity, bone erosion irregularity, and the collection. Then ultrasound can be useful. As I said, that the superficial bone or cortex can assess, or not the deeper thing. As I said, you have to remember that the bone marrow edema or the deeper the bony abnormality cannot assess. But sometimes you can pick up this kind of finding. This patient presented with the injury, with the pain here in this location, and when we put the probe, we could see there's a superficial the cubit fracture here, and this is the kind of this normal bone here, and then you can see this is fracture. The avulsion, fracture avulsion is there. So ultrasound can be useful in this case, although it's not a modality for choice for to fracture evaluation, but definitely you can pick some of these the small fractures or superficial structure by ultrasound. Let's see some of the ligament pathology here. So ligament, what are the pathology which we can see in ligament? That can be sprain, or you can say it's a low-grade injury. Usually seen in a lot of athletes or even the common individual. And then there can be some partial tear or complete tear of the ligaments because of the sports-related injury or age-related injury. So here, I said this is our staff in our hospital recently presented with the ankle sprain. And then we did the ultrasound here. So the anterior talofibular. So this is anterior talofibular ligament. So this is the lateral malleolus, and this is talus. So the ligament were looking normal here. So we thought this is not definitely complete tear of the ATFL. But if you can see, there is a small kind of disruption of the bone here. So we said that there is some kind, just it's not a complete tear, so some kind of sprain or some small the injury or small fracture in this one and the lateral malleolus. And similar same thing later on the MRI was done, and it's showed the same finding by MRI. So here you can see the anterior talofibular ligament, and this is the posterior talofibular ligament. This ligament is intact, but there is small fracture and edema, bone marrow edema in this same location. So ultrasound quite useful and picked up the same finding as on MRI. So definitely ultrasound is a good modality for initial evaluation of these sprains in these patients. This is a case of a complete tear of anterior talofibular ligament. As I said, shown to the previous slide, usually there should be the anterior talofibular ligament. Like here is the normal, on left side is normal ligament we can see here, but here is nothing is seen. So this is a case of a complete tear, chronic complete tear of ATFL. But the important thing is always the main that you should know where to put the probe and where to look for the ligament. And if you are not sure, like many times, like in the early days of doing the ultrasound, MSK ultrasound, you can definitely always compare with the other side if you are not sure about the structure, what you are looking for, where to look for, and then it's always useful. So ultrasound remain is in that way is very useful. That is always you can see what is happening to the other side. So coming to the tendon pathology, so what are the pathology which can see in tendon? Here is a Tenosynovitis, then it can be a tendinosis, then it's kind of partial tear or complete tear as in the ligament. we'll see some of the examples of the tendon pathology, how they appear on ultrasound. So this is tenosynovitis is a similar kind of as tenosynovitis as can be seen in the other area, like in the tenosynovitis in the region of hand, or other tenosynovitis in the knee region or everywhere. So it's a kind of fluid and the synovial hypertrophy around the tendon, and they can show the lot of signal, Doppler Doppler signal. And so it's quite like easy to diagnose the tenosynovitis on ultrasound. Case of tendinosis, so what happens in tendinosis? There are some of the features which are seen in tendinosis on ultrasound. Like normal, this is a normal tendon here, like as I showed earlier also. Tendon is a quite thick, a very compact fibrillary structure, and it can be seen on ultrasound. So you have to see on the short axis and the long axis. This is long axis. So what happens in tendinosis? In the features of tendinosis ultrasound, what it can be, the tendon can be thickened, then it can show hypoechoic echogenicity. Like normally it's more echogenic, but it becomes hypoechoic, then it can be a tendinosis. Then it can show a feature of the you can see some calcification, or making later on it can be like some kind of this partial tear. So here in case of the tendinosis, here you can say this tendon become thick and become more hypoechoic and irregular. So definitely is a tendinosis. So tendinosis is again a very, very easy diagnosis when the tendon is very superficial, and then it can accessible by the ultrasound. This is a very typical case of the tendinosis, tendinosis with the calcification. So if you remember here, like we showed you the tendinosis, which is quite fibrillary compact echogenic structure here. This is the calcaneum here. So what is happening here? The tendon is thickened, is more hypoechoic, and there are multiple calcification within the tendon at the site of the attachment. Apart from that, it's some fluid in the posterior bursa, posterior calcaneal bursa here, and this tendon shows there's a lot of the vascularity here. This long axis and this in the short axis, and there's multiple calcification here. So it's a very typical case of tendinosis with the calcification, and we seen a lot of cases, this time of cases, and they later on these patients can present with the partial tear, and later on maybe some complete tear also because of more of degenerative changes. Later on they can develop the complete tear. Coming to the tendon tear, this is the case of the Achilles tendon tear here. Like this is the Achilles tendon, and this is the calcaneum here. So you see here the tendon is normal. It's attached here. But what is happening slightly proximal? This tendon is thickened here, and this is a complete tear. So this is the proximal portion of the tendon, and this is the distal end of the tendon, and here is a complete tear. So there is a gap between the both end of the tendon. So this is a complete tear of the Achilles tendon, and there's a lot of, there can be some scar or some fluid, and it is always good to tell the surgeon how much gap is there between the two tendons. So if the surgeons want to do some kind of surgery, then they should know that this is kind of gap is there. Another important thing is to tell you this time here that many times the partial tear and complete tear of this tendon looks like kind of borderline. So in this patient also you can do dynamic examination, ask the patient to do the dorsiflexion and plantar flexion, and then you can assess the tendon is completely tear or the partial tear. So dynamic examinations remains the important thing whenever you are doing the ultrasound of the the tendons or the ligaments. So whenever feasible, try to do the dynamic examination also. Let's see some of the miscellaneous example. Like many times you can see this the foreign bodies, like particularly people who are working in the agricultural field. We have seen many of the cases because then they can prick by the wooden stake or something different, and then it come out to with some pus discharge from the dorsal or plantar aspect. And if you do the ultrasound, then you can find this the foreign body. So this patient is typically presented with the pus discharge, and we can see the dorsal aspect. There's a collection here, and then we could see there's a linear echogenic structure here. Is the foreign body here. So definitely in those patients, ultrasound can pick up these findings. Many times, like some of the cases in our institute also, like patient presented with pus discharge and the osteomyelitis were suspected. And then they directly came for the MRI. And then we suspected probably that it may not be just a simple osteomyelitis. And we thought probably we are dealing with some foreign body. So MRI, and then we did the ultrasound on those patients, and then they turned out to be a foreign body. So it's always a good, if you have some suspicion on MRI, and then it's always good to see by ultrasound to definitely see some kind of abnormality by ultrasound. This kind of soft tissue mass also, you can see there's some malignant or benign mass lesion in the ankle or foot region, and then you can assess how big the mass is there. There is some vascularities there. So this case here is a large, big mass, soft tissue mass, and encasing the tendon of the ankle region, and this show a lot of hypervascularity. So this was a malignant soft tissue mass. So, so these kind of like soft tissue mass you can assess by the ultrasound. So it's not a big deal because it's kind of anywhere, the mass is anywhere. So in ankle region also you can assess by the ultrasound. So to conclude that, I'll say that the ultrasound is a very good modality if you want to assess the ankle joint. Important thing I will tell that we should know the anatomy and the technique, where to look for the particular structures. And if you know that anatomy and the normal morphology of the particular structure, how the normal tendon, how the normal ligament appear on the ultrasound, then it's not a difficult thing. And in difficult cases, like MRI should be used. Like I always say whenever I speak to the people, the young radiologist or the people who just do the ultrasound, that whenever you have any suspicion or there's some borderline case, you should not hesitate to ask for the MRI, because MRI provides is a global view of the whole of the joint, and it can detect not only soft tissue structure but the bones very properly, and then the articular cartilage or anything, particularly the knee region where you have to see the intra-articular structures like the cruciate ligament and the menisci. So on those conditions, the MRI can be useful, but definitely a lot of good machines are available, high resolution proofs are available, lot of advancement in the software and the technique. So these things are like now available, and whenever possible, at least we should try to see it. And particularly, like I can tell you that many times the people with the diagnosis of the ganglion cyst, usually the surgeon sent for the MRI, where I think the ultrasound can suffice. So in those situations, I can say that the ultrasound, you should do the ultrasound first, and if it's accessible or it can diagnose by the ultrasound, then definitely ultrasound should be used. And whenever there's a problem, or whenever there's a suspicion, and when we are not sure about the diagnosis, then you should go for definitely can go for the MRI later on. So I thank you for the kind listening, and I again thank you BSRI and all these all the office bearers and the people who are worked hard for doing this webinar. Thank you very much, and I'm happy to answer any question if it's there.
Thank you.